Dear Chairman, dear colleagues, dear Jacques, thank you very much for hosting and organizing this outstanding meeting. Dear Majid, thank you very much for inspiring all of us to this befriended colleagues meeting all over the world. And thank you also for over 20 years ago, agreeing on me going away for a while, for repeated periods, to a second teacher and academician in neurosurgery for the field of DBS, to go to Benabi, to Grenoble, and learn from him this technique. My disclosures are related to studies, and it's over 20 years now that I'm away from Hanover after training in skull base, vascular, and peripheral nerve surgeries. And Würzburg is just in the center of Germany, and an hour from Frankfurt and 2 hours from Munich only. And it's a medieval town with the fortress Marienberg, looking over the city with over 60 churches, and River Main with a fantastic residency castle where the Three Musketeers with Orlando Bloom, the film was done there because Versailles was booked out. So we had a hall in the town, and this town lives on the university and on the vineyards and university clinic. And here you see, if it's possible, you see here the head clinic with all the disciplines in and around the head. And we mentioned already Röntgen discovering the X-rays in Würzburg, but we should also know that, for instance, Alfonso Corti detected and described in all detail in Anatomy Institute the Corti organ, the cochlea. And neurosurgery was founded first as a first unit, first independent department in Würzburg, and was run by Wilhelm Tönnes in 1934. So it's a very important town, and I hope you will all come one day. History of DBS is a story of repeated revolutions. But patients have a lot of fears, anxieties, and hopes. And so we'll go through briefly through what we are doing and what we could do soon. DBS is based on minimally invasive surgical therapy and delivers high-frequency, tiny electric pulses to the diseased area. Oh, okay.
A little better.
Oh, thank you so much. And it must be at a very, it's on. Is it?
It's on.
Is it?
Sorry. That's thing. Yeah, it's working.
Okay, works with you. Okay, thank you. Delivered at an exactly pre-calculated site. And surgical setting is with two sides, the sterile side and the neurological, neurophysiological side. The majority of our patients, 70%, have an awake phase of only 1 or 1.5 hours. So asleep, awake, asleep. And these are the two sides, the surgical side and the testing side. And what do patients fear? They fear to be completely dependent because of their disease, but also to undergo additional lesions from surgery. It's not good. I talked to Michael. Something is wrong.
Yeah.
I'm so close.
Is that better? Go ahead. Can you speak again?
Hello? No. I have the feeling that it doesn't work really. You can't hear me.
Test 1, 2, 3, 4. Yeah. Yeah.
Very close. Like this?
Volume. Yeah.
Is it better like this? Okay, I'm sorry. Sorry. So they are also frightened to have additional lesion from surgery. They wish to get more mobility with less medication, but they also wish that the disease becomes invisible, and all hope, despite all explanations, that disease progression could be stopped by DBS, which until today is not realistic, but it is a silent hope in all patients. Until today, it's always very impressive to to all of us, when a patient is in surgery and we apply stimulation, and within seconds we see immediate improvement, and patients are convinced and happy with this. In 1982, Benabit performed the first thalamic DBS against tremor, published 86, and a few years later only on DBS against Parkinson's disease. And there were many targets following soon. We also participated in Alzheimer's disease study with Lozano. We did also study on dementia in Parkinson's disease. So it's many opportunities with this technique. And especially Parkinson's disease has taken a tremendous road from detecting dopamine deficiency, replacement therapy, and then quite early afterwards, within decades, SDN, DBS, and a revolution in 2015 with directional DBS. Directional DBS goes back to mathematical, computational, and biological investigations by Batson and McIntyre on the distribution of the electric field between the neurons, the cell bodies, and the fibers. And we know that this electric distribution is not even, but an uneven field, and even a well-placed electrode must not create a good response if this is not considered. And therefore, much smaller and directed electrodes came into discussion. And nowadays, we are all using these 3-segmented electrodes in which we can direct the electrical current in various areas. We speak of the volume of tissue activated. And what you see here in this model is that in the majority of our patients, we have asymmetric electrical fields produced in order to have a very individual electric activation or inhibition. These electrodes needed to be controlled in many aspects, and they gave a lot more work to the neurologists to program, because all of a sudden they had double the size of electrodes to control and to program. And we could prove that after 24 hours, the electrode rotation would not change anymore. So stimulation programming would be stable. However, comparing in a study the previous ring electrodes and the directional leads, we did not see major clinical differences. The improvement compared to the medication was about 75% with both methods. But we applied less electrical current, lower stimulation, and lower frequency. So we are much more precise, and this is probably relevant for long-term functionality. When we have to plan surgery, we can't always take the angle of approach that we would like, but we have to pay attention to all the sulci and the vessels, and precision plays an utmost role in this aspect. We perform the microelectrode positioning sometimes in a rotation by 45 degrees to avoid vessel contact or vessel lesioning. This is also important. In almost 600 patients of recent years in our team with Jens Volkmann, we have mainly implanted Parkinson's patients, but also some rare indications. And in over 1,000 electrode implantations, there are 720 directional leads already. And our complication rate is especially low. It's not zero, but it's close to this. We had 3 intracerebral hemorrhages, but no long-term problems from this, all completely recovered. We had 0 infections until all of a sudden, our microbiological stewardship forced us to change our prophylactic antibiotics. And all of a sudden, we had 4 infections coming to 0.8%. So we went back to our previous regimen and had no infections anymore. We control in weekly team conferences exactly the lead position and the outcome in the patient. And so even to change by 1.5 or 2 millimeters electrode position, we do revisions in order to be perfect with the results. However, we understand quite well when we look in the broad literature, in big centers and in big reviews, how high the number of complications, hemorrhages, infections, and also revisions and explantations is. Such like here reported by Ralston, 24% of these lesions and revisions and explantations. This has become better, but still worldwide, up to 7% of hemorrhage or infection happens. And our center, luckily, with a very precise protocol, hold to by everybody, has much less complications. And this is the basis for any future development. We are aware that especially the Western societies are aging societies. So the peak in the society is no longer between 40 and 50, but between 60 and 70 very soon. And this means we will have more and more degenerative, neurodegenerative diseases, which are all toxic protein aggregation diseases, which lead to neuronal cell loss. So I would like to come back to the original work by Benabit and DeLong. In 2014, they obtained the Lasker-DeBakey Medal for their willingness to challenge dogma and to soothe some of the most troubling conditions. The neurophysiologist, Marlon DeLong, the physicist, physician, and neurosurgeon, Benabit, who invented and started this treatment. And he invented a 5-channel band gun, which he uses for the microelectrode positioning for 1 to 5 microelectrodes, which we still use until today, although some colleagues abstain from this, but which tells us immediately where the better peak is and where we will have the best chance to improve the motor dysfunction. And we can see by online spectral analysis easily which of the 5 electrodes gives the best response and at which height and position we should position it. And the modern electrodes, they're also are available not only for this acute, but for chronic sensing in the patient over years. And this is the background for adaptive stimulation. So there's importance to know where to stimulate, when to stimulate, and how to stimulate. And adaptive control by chronic sensing might play a major role. We have brought up a large research council together with Berlin University Charité, with Milano Neurological Institute, with Professor Isaias, and also with colleagues from Boston on imaging. In recent years, the connectomic data analysis has largely influenced the field. The blood oxygen level dependent signal plays a major role to understand the connectivities between certain brain areas and the relation of the stimulation to this. And we know that we can see differences depending on age and on gender regarding this basic, normal, natural connectivity, and also the connectivity used and induced by DBS. By calculating the tissue, volume of tissue activated, and by looking at the connectivities in the individual brain, we can predict how good the outcome will be to specific electrode positions in the patient. And we compared the Berlin group and the Würzburg group of patients, and they could identify when the connectivity is the prefrontal cortex was positive, then these patients had a very special good result. And this applies also to larger areas and also to specific symptoms, so we can address rigidity or tremor specifically. Gait is a specific problem in these patients, and therefore we also not only use the internal chronic sensing, but also the external sensors in our gait laboratory, as you see. So the patient is like wearing a watch at the wrists and the ankles, and thereby we can improve also the adaptation of the stimulation program. But one of the most interesting things is probably this, a red mode, a model to improve by early stimulation, because we detect Parkinson's disease much too late. And we have the idea that when we put stimulation much earlier, we might prolong the honeymoon period of good state. And in an experimental rat model, we could show that the number of neurons that get lost by this Parkinson model could be rescued in stimulation, and especially in early stimulation. Motor response would be better, but the response could really be much improved the earlier the stimulation was performed.
Conclusions, please.
Okay, so I will close. I will just come to the conclusion. So DBS induces significant improvement in movement disorders and reduces the need for side effects and medication. It needs a highly committed team to reduce any risks, and precision and safety are the base for further evolution. The analysis by connectomic DBS may improve identification of optimal lead sites, and analysis of chronic sensing via implanted devices in combinations with external sensors can identify the disease phenotypes, gait phenotypes, and induce adaptive DBS. And Benefit's dream of preventive DBS could become true quite soon. In the name of our interdisciplinary team, I thank you for your attention.